Minneapolis. I didn't hear that. Thank you. I didn't hear it from this side. Come on, people. Wake up, right? All right, we're getting started tonight. This is an MS Views and News Compass to MS Care program. Our program tonight is sponsored by Bristol Myers Squibb, Genentech, Sandoz, and TG Therapeutics. And we have exhibitors. We have Bristol Myers Squibb, Horizon, Infusion Associates, the MS Center for Multiple Sclerosis, the Minneapolis or the Minnesota Center for Multiple Sclerosis. We have the National Multiple Sclerosis Society. We have Novartis, Sandoz, and TG Therapeutics. And I want to thank all of our sponsors of tonight's program. I hope you all do as well. Thank you. And now we're going to have our guest that many people wanted to come here and listen to this evening, Dr. Jonathan Calkwood. He will be speaking about treatment options, a little bit maybe about biosimilars, as well as future treatments, as well as visual issues, maybe a little bit on access to care, and so on. So he's going to be speaking for about 55 minutes, and then we are going to go to Q&A. All right, so get ready because this is going to be dynamite. And by the way, I also wanted to let you all know, though, about Dr. Calkwood. So I know he just recently moved. I don't have any script on him, all right? I know he just recently moved from one MS center to another, and now he's with the Minnesota Center for Multiple Sclerosis, and he's also involved with Infusion Associates. I don't know much about anything except that I wanted to let you all know about that as well. All right, so let's ask Dr. Calkwood to come on up. This is your microphone.
Thank you, Stuart.
And we'll get started.
Super,
Thanks.
Thanks. So we had the consortium of MS Center meeting last week, and there were some really cool things going on there. And I've kind of changed up the topics a little bit, just moved a few things around. So vision and MS, I'm a neuro-ophthalmologist as well. So, and in fact, I do have to thank the MS Society. When I first came here, vision in MS at the time, we've learned a lot since then about visual disorders and multiple sclerosis, but at the time it was fairly new, and the MS Society had me go all over the state, and some of those places I probably still couldn't get to now. I don't remember where they were, I remember the names, but speaking to people with MS about visual issues. So tonight I'm going to include that, but I think one of the most exciting things going on, at least for us neurologists, is the involvement of evolution of something called biomarkers. So we'll start with that kind of. I think first thing you got to say is this whole area is a little bit confusing. It feels a little bit like this slide, that disease, biomarkers, decisions, proteomics, relapses, metabolomics, all sorts of interesting things that are going on in research. And these things are all coming home to roost in a way that is going to help us neurologists and providers care for people with MS to provide better responsiveness to the disease state. So I'm going to endeavor to solve some of this kind of confusing picture here. So first of all, biomarkers. Well, what are they? Kind of self-explanatory maybe. Biological marker, in this case, of disease activity. So these a biomarker gives you some measurable aspect, something that is important and meaningful about that disease. Now, we want to use biomarkers in lots of ways, and there are actually some common biomarkers that we really use right now in our care for persons with MS, and we don't really think about them as biomarkers, perhaps, but I will endeavor to explain some of those. So, in terms of biomarkers of MS, this is what we like to see. We like to see some indication or some measurable way to measure inflammation and the progression of multiple sclerosis. We want to use them to be able to monitor disease and changes in the disease. And ultimately, I think they're going to be very beneficial in research studies. And we're starting to see the first inclusion of biomarkers in clinical research for MS. So here's kind of what we have right now. So if you look, obviously, the tried and true MRI scan, MRI really changed our ability to diagnose the disease of MS. Prior to MRI, we had CAT scans. MS doesn't show up on a CT, but that was the most detailed images we could generate of the brain. So when MRI came along, MRI caused this explosion in our ability to detect the disease and detect the disease early, and ultimately has probably led, we saw the quote-unquote increase in the number of persons diagnosed with MS. Maybe the disease actually is getting more common, but certainly MRI made it a lot easier to diagnose. And so this 1 million or so Americans that are affected by this disease, in part, we capture many of those people, sometimes for symptoms, but definitely MRIs. Now, we can use MRI in lots of ways. We can use it to diagnose, and we can use it to monitor and follow, and we're measuring changes in the brain that are occurring. Now, there's no measure of multiple sclerosis function in an individual that's really going to measure everything about the disease that's going on in that person. So now you see a plethora of different things that we use. I'm going to talk a little bit more about OCT, which was actually something I talked about on my initial tour through Minnesota. Gotta say, that was 17 years ago. So the other thing that has evolved actually since OCT came on the scene is low contrast acuity testing. I'll show you some examples of that. Then we think of other things, biomarkers. Now I didn't put I did put the EDSS and the MSFC. So these are physical measures of people's functioning. So the EDSS, Expanded Disability Status Scale in MS, is a research scale that we use in MS. And it's a little tough. It's not great. It measures the disease. It's not linear. It focuses on symptoms very early on in the scale, and then on disability, gait aids, things like that later on. We use it in research. We use it at the Minnesota Center for MS. We use this as well in a modified form, but it's not quite practical. So another scale evolved initially for research that now is making its way into widespread use, and that is the Multiple Sclerosis Functional Composite. And this is basically, actually contrast sensitivity was recently added into that composite. So there are basically 4 different tests that are done. And they broadly measure upper extremity function, so something called a 9-hole peg test, and then 25-foot time walk, which measures lower extremity function, and contrast sensitivity measures visual function. And then the final thing is really, really important and something we've really only seriously paid attention to in MS in maybe the last 10 years, and that's cognitive problems. So the symbol digit modality is a quick screening test in order to determine if someone is having cognitive issues. And again, this is a chronic lifelong disease, so we actually want to be measuring these things all along the course of someone's life with MS. We can use these to identify when a treatment's not working. In some cases, we can use, low contrast acuity and OCT can be used to identify the disease, to identify someone who's failing treatment. I'll go through a few examples. I'm not going to focus so much on the MSFC because as you go down this scale, you'll see cerebral spinal fluid, that's old news. Oligoclonal bands are a laboratory marker biomarker. So up to now, we've really not talked about we've talked about biological markers in terms of indirect measurement of the brain through MRI, direct measurement of the retina and the nerve cells in the retina in the OCT, and then the physical measures of people's functioning. And now cerebral spinal fluid and immune system activity in the spinal fluid was probably one of the earliest clear biomarkers, although we don't tend to do it regularly. We tend to do that to help diagnose somebody. Obviously, a test that requires obtaining spinal fluid every time we want to get the results. I'll just say the sign-up sheets in the back, show of hands, who's going to sign it on the way out, right? I think so. So that's tough. But that points out something, and I'll talk last about the proteomic biomarkers, which is probably one of the most exciting things we've been waiting for a long time in MS. A way to measure the disease activity and changes in the disease before someone's doing bad, before they have a new MRI lesion. You know, you might not feel that new white spot that shows up on your MRI. You might not feel it now. You might not have felt it when it happened. But on average, people lose 20% of the brain cells when a lesion forms in the brain. That scar, if we look at that, if you do a biopsy and looked at it, 20% of the nerve cells are gone. And then there's a lot of other things, scar tissue and inflammation in that lesion as well. So these proteomics now are actually a way to, we're still not quite getting out in front of the disease and being able to predict where it's going, but we're getting closer and closer. So I want to talk, this is just summary-wise, so I want to talk in a little more detail. So let's talk about what really goes on. So the immune system, and this little cartoon here basically shows aspects of the immune system. We meet the T cells, B cells, and this is the adaptive immune system. So the adaptive immune system is a very complex interaction between cells that basically learn and respond, and so that's where the action is with MS and most of our treatments. We do have some emerging treatments that will focus on what's called the innate immune system, but right now most of our treatments work on the adaptive immune system. In multiple sclerosis, it only affects the central nervous system, so that's the brain, optic nerve, and spinal cord. And if we actually delve into what's going on, there's a lot going on in the brains of persons with MS, and as well as optic nerves and spinal cord. Let's take a look at this, for instance. So this would be a schematic of a normal, healthy immune system. A normal, healthy brain shouldn't have any immune system activity in there. And you see a nerve cell here, you see the myelin sheath, and then all the other interconnections or dendrites. And there's a lot of nerves interconnecting within the brain and the cortex. But never do we see immune system activity there unless there's a reason. So in a normal, healthy immune system, we'll only see immune system activity in the brain if there's an infection. However, if there's an autoimmune disease, we might see something like this. So in the brains of persons with MS, we can see here demyelinated axons. We see some of the players, some of these immune cells that are coming and causing problems, the T cell, the macrophages, these all have roles, the B cell. And if you can see all these little tiny dots, these immune cells secrete tons and tons of tiny proteins. These proteins are how the immune system communicates. So the reason that these immune cells, or at least part of the reason, the part we know about, that these immune cells wound up here is they were called there. And they were called because of these tiny little chemical messengers, cytokines, chemokines, various names. And then there's a lot of other interaction that's going on in the nervous system. When we start talking about proteomics a little bit later, that is really what this is all about, because all this interaction of the immune system, it can tell us something. It can tell us and give us valuable information. So what happens in this picture, let me see, going back. So the end result of a picture like this, of all this inflammation, might be this. So demyelination is one thing. If you strip the myelin off a nerve and the nerve survives, it can regenerate. The myelin can regenerate, but nerve cells are precious. After the age of about 19, 20 years old, we don't grow any new nerve cells. We're still myelinating, fortunately. I was glad to have that knowledge when I had teenage sons, and now that they're in their late 20s, they're fully myelinated and they're making better decisions. So, but they grew all the brain cells. We all did. We grew all the brain cells we're ever going to have by the time we're 19, 20, maybe 21. And then we don't grow back. They don't grow back after that. So if we get to this final sequence here, there's a little, I don't know if you see that in the back, but there's a little break in the axon. Once that happens, now the axon is that long wire of the nerve cell, and that's the part that's myelinated. But once the myelin is stripped off to the point where that nerve cell can't survive, if it breaks, it's done. it's going to just dissolve away in both directions, and then it's gone. So, and again, we can't grow them back. So early detection really is probably our most important thing, not just early diagnosis, but identifying a person with MS who's failing their treatment before they have a major relapse or before they're making new lesions that killed 20% of those neurons. So ultimately, this is what we want to prevent. And another, I would say probably misnomer, at least of the relapsing remitting, I've been on a personal mission to purge the word remission. It should really not ever be in association with the disease of MS. The disease of MS never goes into remission. Your immune system may change over the course of your life, and it may become a little less aggressive in attacking your nervous system. In between relapses, people are not in remission. And I think it tends to lead to a false sense that, and I actually hear it in the clinics often, oh, I'm fine, I don't need to be on a treatment, I had a relapse, and I got better, and so, but I'm fine, I'm in remission. No, you're not. So I would really like to purge that. So what we have to understand is even between flare-ups, even when we don't see new lesions on the MRI scan, we see there is this constant assault on the nerve cells, an inflammatory assault, low level of inflammation going on all the time. Doesn't show up on the scans, doesn't show up anywhere. Over time, it shows up as a gradual loss of brain cells faster than aging. Hence, brain atrophy is a thing we have to keep in mind, and something else we're watching for more and more now on MRI scans. Well, how the heck do we know? How do you know if your treatment's working when low level of inflammation can be picking away at your nervous system all the time? Well, there's several ways. The way we don't want to figure that out is when you've already had a relapse or when your disability has worsened. You might recover and improve following the relapse, and you could even improve following a slow worsening of disability, but you don't really recover back to your baseline. And the accumulation of those deficits over time is what leads to the big D, the disability word, and that's what this is all about. In a lifelong disease, we have to take a long view. So how do we figure that out? This one should have a quote. Managing MS is like driving the bus while looking in the rearview mirror. Your neurologist is always reacting to what has already happened to you. That's me, that's my quote. So this has always impressed me about this disease and what we have to do to manage it. And this is also why we need you and your family members and everyone as partners in this to identify when things are changing with you. We need you to call us and let us know. We need your family members to tell us what observations they're making about changes in you as well. It's really hard. Everything, including biomarkers I'm going to talk to you about in a minute, are looking at what is, biomarkers may actually be right at the bumper of the back of the bus, but by the time we see an MRI change, by the time we see a relapse, these are all things that have already happened to you. We would love to be in a position, and I'm sure probably you would like it too, if your healthcare providers were in a position to identify problems before they occurred and head them off. So this is just kind of a brief schematic of sort of what the life and journey of someone with MS, from the timeline across the top where you see a diagnosis and then there's decision to place somebody on a disease-modifying therapy. Then typically what we're doing now is doing new baselines of imaging, because a lot of our disease-modifying therapies take 6 months or more to become fully effective. Essentially, we're baselining, doing a new MRI, doing a new neurologic exam, collecting those biomarkers that we have always used, tried and true, probably since the early 90s when MRI became more widespread. So since then, we've essentially been using neurologic exams, disability scores like the EDSS, and tracking people's relapses in order to tell if our treatments were effective. And so as we see along this course or lifespan, there might be a situation where someone has a relapse or an MRI change, some breakthrough disease, and that would then prompt should we consider a change in treatment. But this ongoing check-in where we're doing exams, neurologic exams regularly, typically every 6 months, at least someone early on in disease, although later on disease, your providers may decide that it's not quite as important to follow you as often or as closely. But this is the way we identify these check-in points. So your MRIs are fine, your neurologic exam is good, you're not having new symptoms. Now, we've been adding some of these measures of upper extremity function, lower extremity function I talked about, of MFSFC, because it's more sensitive for detecting change than the neurologic examination. And these are validated tests. So if you lose 4 symbols on the symbol digit modality test, that might be a significant change in your cognitive function. So we can actually tell if something's changing. So biomarker, this is a familiar one. I'm going to go through a few of these biomarkers now. MRI we're pretty familiar with, so the brain and the spinal cord. So you see on the right side a brain image and the spinal cord image on the left side. So we can use biomarkers, and we use the biomarker of MRI we use both to diagnose the disease, we use it to monitor for change over time, and actually we use it to gauge severity. We've learned that lesions occurring or concentrating in certain places like the brainstem and the spinal cord can lead to greater physical disability if someone's MS is selectively attacking the higher cortex or making lesions close to the surface or gray matter of the brain or causing black holes on the MRI scans, then that's going to lead to more cognitive disability. So the MRI can help us in lots of ways to gauge the disease, track the disease, and monitor response to treatment. So I'll introduce you to OCT. I've mentioned it a few times. And just briefly here in this diagram, we see the this is a picture of the back of the retina, the very center of the back of your retina. This is an OCT image, and the place where your vision is most acute, the place where we need to read and see distance detail, is in this part of your retina, right there, the fovea, the macula. Now, this schematic here shows you the layers of the nerve cells in the back of your retina. This upper layer is a nerve cell layer, and then this layer in here is also very important. So we've learned that MS impacts these areas differently, that these upper layers, what we will see over time is they will gradually change as people with MS are losing brain cells, and often we see that faster than aging. We can measure that in your eye. We can measure what's going on in your brain. You have to think the eye is a projection of your brain, and it's readily accessible. And the OCT test is just able to measure with exquisite sensitivity, about 2 to 4 microns of resolution. I asked this question to audiences. Is there an engineer here? Someone must be an engineer here. No? We don't have an engineer? I'll play the part of the engineer. At programs where I talk about microns like this, and then if there's an engineer, I say, how much is a micron? Invariably, engineer, precise mathematical person goes, about that much. So I was kind of hoping to see if we had one tonight. But it's very, very small. And we can essentially detect, you have 1.2 million brain cells in each eye. This test is so sensitive, it could tell if you lost even 1,000 of those brain cells. On an MRI of your brain, you might have to lose thousands and thousands, maybe hundreds of thousands, maybe even millions before we could actually tell. So very important. Again, we have to think of all biomarkers. Advantages of biomarkers are best when they're non-invasive. They don't require like a spinal tap, for instance. They're highly sensitive, as OCT is, very sensitive and high resolution. And obviously you can have the best test and most sensitive test in the world, but if you can't pay for it, if the insurance won't pay for it or cover it, then that test is inaccessible. Shout out to the MS Society for helping to get more accessibility. This is typical advantage of any biomarker. It has to be easy to use, it has to be accessible, it has to be cost effective, and it shouldn't either hurt. Now, the night is short, and I won't go into all of the ways other than to say OCT is a powerful biomarker. It's one that's relatively underused. Neurologists don't understand it very well. Ophthalmologists don't understand the neurology part as much, but OCT testing is readily available in every ophthalmologist office. Many of the MS centers are now actually doing OCTs regularly. This is very gratifying to me because when I was touring Minnesota talking about OCTs and talking to other neurologists about it, because that same year I came here, I did a national tour all over the country talking to neurologists about OCT and MS, and I got blank stares. It was like, oh, see what? OTC? But now it's really become mainstream, certainly amongst MS specialists, and I think even the ophthalmologists are starting to pay a little more attention to the neurological aspects and how they can help your neurologist take better care of you. Now, this is another biomarker that has emerged since OCT developed, contrast sensitivity. So I've tried to indicate here that this is a black on white background, and then this chart down here is that one actually. The actual eye charts we have you read, I couldn't put up here because they're so dim you wouldn't be able to see these letters. It's really, a lot of my patients get frustrated because they say, that last chart, it makes me crazy. And they expect that they should be able to read all the way to the bottom of it. No, nobody ever reads all the way to the bottom of that last chart, the dimmest one. But most importantly, we know that a 7-letter change, if we're doing this regularly on you, and if you lose the ability to see 7 letters in one eye, something happened in that optic nerve. So it's a very sensitive marker if a relapse, essentially it was a subclinical relapse in your optic nerve that didn't cause enough symptoms that you would have called us or you would have noticed anything, but yet we can identify that something happened. And if you're on a disease-modifying therapy, we know there might be a problem. Now, I may not react to just that change, but it's going to make me look very carefully at that individual. And very soon we'll have a few other measures we can do to find out if the OCT change is correct. But again, inexpensive test, easy to do, takes a few minutes, and very reliable and reproducible. Now, this biomarker has a few problems because it's not just specific to MS. If you developed a cataract or something, or if you had really dry eye or inflammation in your cornea, it might get worse. So there are other things besides MS that might change this one. All right, so serum biomarkers. Now I'm going to shift. We're now getting into the world of much more recent things. In the past 5 years, really. So, and this was really probably our first serum biomarker. We've known about neurofilament light chain decades and decades. We've known that in the spinal fluid of persons with MS, neurofilament light chain is elevated. And we've known in the spinal fluid that when the disease gets worse, or if someone has a relapse, that the neurofilament light goes up. We also know that over time, if someone's disease is poorly controlled, the neurofilament light will remain elevated and may gradually increase over time, although with aging, it will slowly decrease. I'm sorry, I said that with aging, it will increase. So you have to kind of sort that out, the differences between aging as well. Now, if you look at the schematic, these little squiggly proteins here, they are looks like our battery is dead there. So those little squiggly proteins are supposed to be inside of that nerve cell. So when that axon breaks, when it dies, those proteins are spilled into the spinal fluid, and then eventually they seep into the blood. So the biggest development recently, say maybe 7-8 years ago, this was first presented at an MS meeting. We developed a sensitive enough test to measure this in the blood, because same thing, we could have the most sensitive test in the world, but if the insurance doesn't pay for it, if it's difficult to get the information, if you have to have a spinal tap to get that information, nobody's going to sign up for that, and then it's a great biomarker, but pretty much useless to us. So this was probably one of the first ones to go big time, and I think 2 years ago now we got a commercially available test for this. So this is now one we can do on our patients. This is actually a poster from the ACTRIMS meeting here in the U.S. It was in San Diego this year. The ACTRIMS European meeting occurs in different places in Europe once a year, and the ACTRIMS is the American version of a focused MS meeting, North American version, I should say, and it. So we're seeing a lot of high science and data presented, but this was a poster on a proteomic biomarker panel for multiple sclerosis. Now, if you see here, in fact, let me just go to the, yeah, I think the next slide should have a little bit. There, you can see this a little bit better. So it's very interesting the way they came at this. So they essentially drew blood on a few thousand MS patients. I think it was actually under 1,000 initially. And then they looked at how those people were changing over time. And then they used essentially the ability of, it's not exactly artificial intelligence on this, but supercomputing power, really able to screen and say which of these, all of these little tiny proteins in the blood, so which of these are the most important? And they correlated that with changes in different aspects of people's disease of MS. And if we see here, these are broken down into my pointer worked again. So myelin biology in this blue sphere. So there's a biomarker here called MOG. We actually do a blood test now when someone is diagnosed with MS, because there's another, we think it's probably not MS. It's called MOGAD, but we won't get into that one too much. That will put me off my 55 minutes if we get into that one. But so myelin biology, and the other sphere is neuronal integrity. So and that one you can see right there is the neurofilament light chain, the one that we've already identified. And then if you look at this other sphere here is neuroinflammation. And then this sphere is immune modulation. So these are probably the biggest spheres of activity going on inside of your brain. If you go back to that very busy neuron slide with all of the immune cells and all the proteins and the cytokines being released, this is a combination of different. These aren't cytokines. Some of these are cytokines. Some of these are other chemical messengers. But these are all part of that complex interaction that's going on in the immune system, in the brains of people with MS and in their immune system. So then this is actually what we will very soon be able to get. So we'll be able to draw a blood test. We'll send that into a centralized lab, and then we will get this report. We, as in your doctor or your provider, will get this report that will list these biomarkers, and they've essentially assigned a disease activity score. Now, this is our very first time around with something like this in a major way, and there's going to be a lot more to come. So we're really just seeing the first wave of something hugely important that's really going to change our ability to manage MS, to get out in front of this disease before it causes somebody problems. So I think this is very, very gratifying to me. Me personally, to be able to do that. And that, Stuart, that's why I changed up the program, made it all about me. But I think this is really important. It's certainly important for your providers, but this is definitely going to trickle down directly to your day-to-day MS care. And it's coming really fast. So stay tuned. We're going to be talking more and more about this. Now, this is the proposed mechanism. I borrowed this slide from the folks from the company Octave. It's called, it's not projecting very well, but essentially this was that journey that we were talking about from the time of diagnosis. And now, rather than just MRI, OCT, various biomarkers we do every 6 months to a year, the MRIs, the OCT, the contrast sensitivity, neurologic exams, MFFCs, all of those things. Now we're going to add these little reports that we will be able to get as well. Further confirmation if you're doing well, or maybe identify someone who is maybe not going to do well before they're not doing well. Yep. Confusion. management of MS, yeah, it's busy. There's going to be a lot going on, lots and lots going on. So stay tuned. There's a lot more that's going to be happening here. So I'm very, very excited about this, and we're now, I believe this test is now being done in over 40 MS centers, and very soon we'll be doing it as well. And I think you'll see more and more adoption of this, and I hope that every single one of you has the ability to have someday some sort of laboratory biomarker assessment. I think this is going to be really, really important. It's important now, the biomarkers that we do have, but in the future, even more important. So I'll take questions on all of that at the end, but I want to shift gears just a little bit and talk about something else that's going to be very important and improve access to care. Kathleen referred to this earlier, and access to care as well as what the MS Society is doing. I think the probably one of the bigger issues that we have in this country in terms of access to care is affordability, right? I mean, especially drugs that cost thousands and thousands and thousands of dollars a year to maintain someone's MS, and that's difficult. I see this day in, day out, because the cost of these drugs drives the insurance companies into a frenzy. And then the insurance companies turn around and start putting in all sorts of archaic rules that really don't make sense for how we should be taking care of people. I think the insurance industry wants to do the right thing, well, mostly, but they're also charged with controlling the economics. You know, they can't provide your health insurance if they go out of business. But it still becomes an issue, and the more we can do to relieve that financial pressure, the better. So we are on the cusp of many more generics and biosimilar. I just want to point out there is a difference between a generic and a biosimilar. So generic drugs tend to be small molecule drugs. They're actually a lot easier to make than some of the biological drugs. So a generic drug can also be assayed and measured. So a small molecule generic, you can do an assay on a bench in like a lab, a research lab, and actually get a really good indication that a small molecule generic drug is going to have the same properties, effects, positive effects, side effects too, all that, as what we call the reference product, the originally rigorously FDA reviewed drug. And so a generic is a little bit easier to compare the generic doing just a laboratory assay. Now, when a drug company funds a research study in order to get a MS treatment approved, they usually have to do a couple studies. They have to be at least 2 years, and one of them has to be at least 2 years long. Now the FDA is actually requiring having active comparators. So rather than compared to placebo, which up to maybe about 7 or 8 years ago was really the standard, and now we really need to compare drugs not to doing nothing, because doing nothing for someone with MS, as in not putting them on a disease-modifying therapy, is just not ethical. So I had actually stopped doing placebo-controlled research studies in MS 5 years before the FDA finally shifted, because it was really clear, even 2 years in a placebo group, that person is never going to catch up to where their neurological abilities could have been. So it's just not ethical. But now more and more we're seeing active comparator research studies. And those studies are really expensive. For a disease like MS, where it's really hard to measure, MRIs are expensive, and we have to track people over a long period of time to tell whether our treatments are effective. So a typical development program for an MS drug, maybe there's 120 million, 140, 50 million just invested just in doing the actual research. That's before there's any marketing. The FDA charges $1 million to review anything that's submitted to them. So it's expensive to do this research. And so one of the issues that has kind of slowed down biosimilars, and now biosimilars aren't small molecules. They're very complex molecules. They're difficult to make. It's harder to make them the same and be reproducible in how you create them. And because they have complex interactions in the body, it's even harder to tell if a biosimilar drug is going to have exactly the same impact as the reference drug. So this has actually slowed us down. I think we've had some positive change recently. And essentially some of that has been the FDA. So I've already kind of gone through what's on this slide, but the FDA-approved biosimilar drugs are now, well, we've had a little bit of a change in their approach. We can have a little less rigorous approach. They can demonstrate equivalency in other ways without doing a $120 million study over 2 years or so. But we, as clinicians, providers, neurologists, we're skeptical of a drug that has complex interactions until we've either seen data that it really works. And I think over time, we finally kind of have come to arrive at a place where we're getting much more comfortable with biosimilars having the impact that we expect. So I'll just step through a few of these. The approval process, again, can be quite horrendous for these drugs. The FDA recently eased that somewhat. But biosimilars still have to demonstrate equivalency at some levels. They just don't have to do that 2-year research trial. So this is the abbreviated pathway that I mentioned that was developed. And this pathway certainly is provided for more rapid access, lowering cost, and really increasing access to some of the medications. This isn't just for MS, this is for all biosimilars. So we are really approaching a time now. We actually have had our first biosimilar drug in MS. It is the so-called generic Copaxone. It's not really a generic drug, it's really a biosimilar, but it is a complex molecule. And we're coming up very soon on a biosimilar for Tysabri, natalizumab biosimilar. I actually recently very pleased to see there's been approved, this is off topic here, but important for some folks with MS, spasticity management. There now is a biosimilar Botox, botulinum toxin A. Just started reading about that one, so I'm kind of interested. This one apparently lasts like 6 months, where the others only last 3 months. So don't know that much about it. I'm learning about it right now. But so biosimilars will have an impact of lowering the cost of healthcare, increasing access. Hopefully, maybe the insurers will be a little more comfortable. I mean, they're in general right now, they're very much ready to go and promote biosimilars, and that's certainly what we saw with copolymer 1, the so-called generic Copaxone, that the insurance industry adopted it rather quickly. So this is going to be more and more important going forward, and I think I just want to skip up to, so the data involved, again, the clinical trials are important. Pharmacokinetics, pharmacodynamics, all these things don't mean much to you guys, but this was taken directly from the FDA's website, so this is actually the language that they're using. They do need to prove some degree of interchangeability. And then this, I think, is probably, and this study now is a little older, but they've now done, after a systematic review of over 90 studies where patients were switched from a reference drug to a biosimilar drug, that we have really not seen any differences in safety, effectiveness, immunogenicity is causing abnormal immune system reactions. So I think we really have finally arrived where the equivalency of biosimilars, we can be much more comfortable with that now. So, and again, that's going to have some of that positive impact on increasing access to treatments. Again, hopefully the insurance companies will calm down a little bit. They'll be spending a little less money, and we can still get highly effective drugs that are going to be more accessible, have similar side effects, have equivalency and effectiveness, and more access. That's kind of what it's all about. So I will, at this point, brag to Stuart that I finished early. So, be happy to take any questions at this point. And Stuart, do you believe it? It wasn't
First,
2 hours?
I think that everybody should thank you and Kathleen for speaking.
Oh, yeah. Well, thank you. I would be remiss if I didn't thank Stuart, because I had the experience the other night of going, and I've seen, you know, all these things get put up on Stuart's YouTube channel. I went through MS Views and News YouTube channel. It goes on and on and on. Stuart talks about traveling all over the country. You know, he's on the road half the year, basically. Go on his YouTube channel. You can see what he's been doing. Oh my God, it is a huge body of work. So what Stuart has done, and his team, it's not just you, but you've been the driving force. I mean, you started this. So MS Views and News has had an impact on person's lives. You only have to go look at the YouTube channel to see how many people have viewed all of these videos. So Stuart, shout out to you and the crew. Thanks, guys. Yeah.
Thank you much. So who's first in the audience? Okay, I don't have to walk that far, thank God.
I just have a question about what the impact of the biometrics have in the area of things like PML.
Biometrics in...
I'm sorry, biosimilars.
Biosimilars, okay.
Like nothing, because that's not a thing.
So, you know, I think at this point we're comfortable in saying that biosimilar drugs are going to be very, if not exactly identical, so close to the reference product. And while we focused on safety, and the FDA focuses on safety, effectiveness, I think if we have a natalizumab biosimilar, a Tysabri biosimilar, we will assume, rightly so, that the risk of PML will be exactly the same. So, and I think with a biosimilar, unfortunately, I don't think it's going to lower the risk of PML. And of course, PML, for those of you who don't know, progressive multifocal leukoencephalopathy. Say that 3 times fast, right? That's why we just say PML. So progressive multifocal leukoencephalopathy is caused by a virus called JC virus. That virus doesn't cause disease in humans. It will if they're immune suppressed. And so we primarily see this type of infection. It's an infection in the brain, and it is quite serious. People on natalizumab have about a 22% mortality rate if they get that infection. We actually see it profoundly in people with HIV, cancer patients, transplant patients. People with HIV who get that almost uniformly die. It's a very, very serious infection, and we don't have a treatment for it. So monitoring, prevention, and there are only a few things we can do right now. But your immune system is very effective at fighting PML, so essentially restoring immune function when someone gets the infection is one of the few things that we can do to help them fight it off. But it's a very serious thing if it happens. So good question. Thank you.
Thank you for that. I got a question to go further along with on top of that for you. This is my own question, right? If a person is JC positive right now from Tysabri, will they remain JC positive if they're using the biosimilar natalizumab?
Yeah, so they will. So if you're positive for the virus, you're positive for the virus. So what does that mean? So we're not actually measuring the virus in your body. What we're actually doing is we're using your immune system to tell if you've been exposed to it. So we're measuring antibodies against that virus. So one of the most important tools that we have in keeping people safe on a drug like natalizumab is this test for the JC virus, what's called a JC virus index. So that index is essentially a measure of the antibody that is currently, the amount of antibody that is circulating in your blood at that time. Now, it'll go up and down a little bit, but one of the more concerning things, if we see a gradually rising titer, if that is going up and up and up, that's concerning for PML. that it might be in the process of developing. PML is a very slow-moving infection. It doesn't really cause, the symptoms come on much more gradually than MS relapse would. And we can identify the tendency and identify the risk. We've done research to know that the risk correlates with how high the antibody levels are. So if we see someone with a higher level of JC virus antibodies in their blood, then they're at greater risk of getting the infection. And that's very important. It helps guide us. Actually, Stuart, you just defined another biomarker for us. So the JC virus index would be a biomarker of risk, but yet another biomarker, and one that I neglected to include. Maybe it would have taken me 2 hours if I had included that one.
Thank you.
So yes, they're different. If you're positive for the virus, you're going to stay positive for the virus, and it really has nothing to do with the natalizumab. It has to do with your immune system having been exposed to the virus and those antibodies being present.
Thank you. Next question back here.
If your OCT eye exam shows no change, is it safe to assume then there would be no change in your brain as far as axon loss or whatever?
Yeah, good question. It would be really nice if we had a test that was really 100% specific and 100% sensitive for what it was supposed to detect, but we don't. If we had such a biomarker like that, that would be all we'd have to do. You wouldn't have to have an MRI, you wouldn't have to have spinal taps, you wouldn't have to have blood taps. So no, unfortunately, that's unfortunately not the case. So
next question's back here, and then we're going to take some from online.
I have a question regarding MRIs and how often. Hi, how often you should be using an MRI as your how you track your progression, and then just the brain, just the spinal cord, both contrast, non-contrast, that type of thing.
Yeah. So. Yeah, there's a lot to unpack there. So let's start with the frequency of MRI. It's gonna be determined essentially kind of where you are, where someone is in their disease. We tend to do the MRIs. Let me back up. MRI measures inflammation, and it's a very sensitive measure of inflammation. But the disease of MS changes over time. It becomes less and less inflammatory. So in general, MRIs are going to be much more sensitive around the time we're using them to diagnose somebody, and very sensitive. We actually have defined these two, life cycle-wise, two peaks of inflammation in persons with MS. Early on, pediatrics, so kids in their early teens, big peak, the disease is very inflammatory. They have a lot of relapses. They make a lot of lesions on the brain, active contrast enhancing lesions. And then there's another peak of inflammation we see, which occurs typically around the age range of the mid-30s or 40s. So there's another period of time where we see the disease. We have no idea why this happens, by the way, but we see the disease will really become much more inflammatory, and where we might start seeing more lesions on the MRI scan. So the frequency of the MRI scan is kind of determined by sort of where people are. Later on, when someone's age-wise, later on when someone's in their 50s and beyond, we're less likely to see new lesions appear on the scan, new discrete lesions. We're a little more likely to see old lesions that are gradually enlarging. And so the MRI changes more slowly. So that biology of the disease drives the use of that particular test or biomarker. So we're going to tend to do that very early on. I can tell you my practice is to obtain a baseline after starting a new treatment. And because we know that the treatments take a while to become fully effective, we typically are baselining at about 6 months. So initiate the new treatment, give it time to work, then we draw our line in the sand. So that's important, because if we do the scan right when you're starting on the treatment and you get a new lesion or so before the treatment's had a chance to become fully effective, we might falsely conclude that that treatment isn't effective for you. And now I'm actually gratified. I've been doing that clinically for many years, and now most of the newer research trial designs in MS are doing that baseline at 6 months. So I think that's becoming fairly generally accepted now to re-baseline. And I'm not just talking about the MRI. We do every biomarker we can biomark at that 6 month mark when we initiate a treatment in some way, whether that's a treatment change or a brand new treatment initiation in a person who's just been diagnosed. So that's an important importance of MRI. You mentioned contrast. Now, contrast is going to be important to detect active disease. And if there's a new lesion there, well, let's talk about a lesion. A new lesion on the brain MRI, when it first happens, is going to be leaky. There's a lot of inflammation. The blood vessel wall opens up. The contrast that's floating around in your blood just leaks into that lesion. So that's how we identify that that lesion is active. Now, that doesn't mean that other lesions in your brain that aren't enhancing aren't active. It just means they're not as active if they're not enhancing. We call it enhancement when the dye leaks into the tissue. So the contrast dyes become controversial about, also that's probably about 8 years ago now. We identified in stroke patients that when they got MRI scans with contrast dye, that contrast dye stayed in their brains a long time. Now, we know of absolutely no problems that contrast dye causes. It's paramagnetic, it's inert, it doesn't seem to interact with the body at all. We haven't identified any problems that it's causing, but it's a little creepy that it's hanging out there and staying there and not being cleared. So it's more of a problem in stroke patients, but we can also see it in MS. And so lately, we've been moving more and more toward a trend of not doing contrast unless it's necessary. So I'm now more and more offering people to say, we don't have to do the contrast. There are other reasons too medically. Some of the contrast might, if someone has a kidney problem. So in general, I think we're moving away from contrast. If we do an MRI, if you have an MRI done and there's a new lesion, there are a few circumstances where we use contrast. I would definitely do contrast at the 6 month baseline scan, because the most important thing we're going to tell on that scan are there active lesions. If there's active lesions at 6 months, I'm worried your treatment's not working, because that lesion is only going to be active for maybe 6 or 8 weeks. Okay, so it's a defined period of time where the lesions will be active. So very good question, complex question. So later in age, we don't tend to do it as often. The contrast, there's actually new guidelines recommended by a consortium of MRI types, Magnumus it's called, and they're now recommending primarily doing brains, not doing spinal cord, or not doing spinal cord routinely. Now, that's a clinical judgment between you and your doctor, because if, in this criteria, if your flavor of MS is selectively picking on your spinal cord, then yes, we should monitor your spinal cord MRIs regularly at a similar frequency as we're monitoring the brain MRIs. But in most situations, we're going to be doing brain MRIs more often. And I do the brain and the cervical MRIs probably a bit more frequently in people who have active lesions, or if they've had a disease in their spinal cord. I'm going to monitor the spinal cord, the cervical, a bit more. It also comes down to a resolution issue. I need 2 hands for this. Say it loud. Your brain is this big, right? Your brain is this big. How do I do that, Stuart? Okay, you saw that. Your brain is this big. Your spinal cord, the lower part of your spinal cord is only as big around as my pinky. So slicing an MRI image through that, you're not going to see very much. So the thoracic spinal MRI is just it doesn't help us as much. Now, very, very important. If we're not looking at your MRIs of your spine, we're still measuring what happens there, because we're doing your neurologic exams, we're doing your 25-foot time walk, we're doing your 9-hole peg test, we're doing these measures of function. So because the MRI of the spinal cord is less sensitive, we do them maybe less often. We don't trust them as much, but we use other data to compensate for that lack of sensitivity. So that's, again, why there isn't just a single a single biomarker to your question that we could do. It has to be multiple. They have different sensitivities. So the more ways we're measuring what's going on in MS, the more likely we are to pick up something before there's a problem. And that's, again, the proteomic biomarkers, where we can actually get almost to the rear bumper of the bus. It's where I want to be. I actually want to be, I want to be looking forward from driving the bus, but we're just not there yet.
Thank you. So everybody that's raising your hand, I'll get to you in a little while. Right now, we're going to take some questions online, and then we'll get back to the audience that way.
The first question that I have.
Speaking to a hot mic.
I am. The first question I have is, who would administer an MSFC, and what kind of doctor would it be?
Yeah, so MSFC, typically neurologists are going to be doing that. The neurologists themselves might not do it. In our center, we have our support staff helps out, so our scribes can do it, our medical assistants. So it's actually pretty easy to do. It takes about 15 minutes to train somebody. The main reason it's not done a lot has to do with just the business of a neurology practice. Getting that in the workflow. My nurse Brenda attended a session at the consortium of MS centers this past week, where that very issue was brought up, of what centers are actually doing this, and there were a lot of MS centers who were, and then the question was, well, what? And then a lot who weren't, and the question was, even of those centers who were they doing it on everybody? And it's like, well, no, it takes a lot of resources to do that, but I think the type of, it can be anybody who does it, but essentially it's usually going to be a neurologist or someone under the umbrella of neurological care. In some cases, there are neuropsychologists that do elements of the MSFC. So when we send somebody for a cognitive test, the neuropsychometrics is probably the most sensitive cognitive testing we have for changes in MS, but it's difficult. It takes 4 hours. Anybody ever had one of those 4-hour battery cognitive tests? Oh, it's miserable. And you can't really repeat it any more than every 3 years. So the single digit modality is something that would be done maybe by even a neuropsychologist. I'm sorry, multiple sclerosis functional composite, and it includes, so the question was, what is the MSFC? And that includes the 9-hole peg test, upper extremity function. I didn't show any slides on it. So lower extremity, a 25-foot time walk, and then the cognitive single-digit modality, and the vision screening is contrast sensitivity. I think a lot of the MS centers that are doing that aren't doing contrast sensitivity. It's my personal mission to get that used a bit more too. So it's gradually getting more uptake.
Thank you, doctor. I know there's a tremendous amount to answer to every question, but we have to shorten them up a little bit because we got a lot of people online and a lot of people here that have questions. Okay?
Absolutely.
Next online.
Regarding the NFL biomarker, do you think that blood taken immediately post-infusion would give different results if the blood for this test were taken between infusions, when the body has had time to heal from the onslaught of the DMT?
No, I don't think it's really going to make any difference. Any of the infused medications for MS wouldn't really affect it. They don't cause nerve cells to die. So the only reason your neurofilament light goes up is if nerve cells are dying and splitting open. Now, it might be MS, but if an MS patient gets a concussion, their neurofilament light chain is going to go up. So we have to understand it's not specific. But no, it would not be impacted by a disease-modifying therapy infusion.
All right, one more online and then we'll go here.
Is the generic Impura a biosimilar or a true generic?
That's a good question. I'm not sure I know the answer. I think it's a small molecule. We have someone who used to work for yeah, small molecule, right? Yeah, no, it is a small molecule. Yes, I had to dig back for that. So yeah, it's a small molecule. It blocks potassium channels, to keep the potassium higher in the cells. So yeah, so yeah, that's the answer. Sorry, Stu, I'll keep it short.
Gotcha. It's a real drug.
It's a real drug.
Absolutely.
Yeah.
It's not a generic.
Dalfampridine. Well, there's a generic small molecule, dalfampridine. So the original Ampera, in fact, it had another name, fampridine, dalfampridine. So, and it had another name before that. But so the product that we have now, Ampera is the trade name. Dalfampridine is a small molecule generic.
Thank you. Next.
Hey, so Dr. Calkwood, the MSDA test, you said soon. Do you know how soon? And also, my other question is about so-called smoldering MS. And what do you think about the studies being done on this and the innate immune system as being more important than even an MRI?
Let me take that one first, and then I'm going to need you to repeat the other question. Smoldering MS was also a really, really huge and interesting thing. I actually even thought about presenting something about that was at the meeting last week. We're trying to get at this aspect of MS where we seem to be controlling the disease in every measurable way, minus the biomarkers we're going to have soon. And yet people are still just slowly getting worse. So we've learned a while back that the immune system, which doesn't belong in the brain, kind of sets up shop, and that smoldering inflammation that they're talking about is immune activity that's just sitting maybe on the surface of the brain, in the meninges and the coverings of the brain, not in the brain tissue itself, but cytokines, antibodies, basically things that will sort of stir up the disease. Most of our MS treatments don't work inside the brain. They work outside, or they keep the immune system out of the brain. So smoldering inflammation is essentially kind of what we're focused on to try to get at this low, kind of gradual loss of neurons where people are just losing brain cells faster than aging, even not having relapses or anything. So we will have, and I think some of these molecules that actually penetrate into the brain, there's hope that we're going to see greater impact on that slow progression part of the disease. And I'm sorry, your first question?
It was the MSDA, I believe, the test.
Need you to repeat all this.
Yeah, that's actually was Octave Bioslide. That's the company that is developing this biomarker test. So that's their report, and it described it as a multiple sclerosis disease activity measure. So that's what that meant on the slide.
When will that be available?
It's available now.
Really?
Yeah, it's available for inflammation. They're still working out some of the details to get the right biomarker changes to identify people are progressing, and that's going to take a little while longer, but that's going to be even more helpful, or certainly additive to the inflammatory markers.
Stay tuned, everybody. I'll be
tuned.
interviewing them in a couple of months.
Oh, will you?
Yes,
Oh,
sir.
Awesome.
Yes, sir.
Dr. Calkwood, I just had a question. I know you didn't speak to this, but I've been reading a lot about stem cell treatments, and I just wanted to understand, I know in the U.S. it's kind of hit or miss. I know Mexico, I've been reading a lot about different countries, but I'm just trying to understand the progress here and what you're seeing, what you're reading, because I've read some, but obviously you know more, so I just want to find out and kind of understand, is it coming here, is it more about insurance, or what's going on with that?
Yeah, well, no, stem cell treatments have been here for a long time. You can talk to a couple of movie stars that have had them done. So yeah, that's exactly where you heard it. So, and unfortunately, we've had many of our patients who've taken out, well, not many, a few have taken out a mortgage and gone down to Mexico to have something done to them. So right now the status is we actually have a phase 3. So phase 3 clinical trial is the last stage of research before something can be approved by the FDA. So we have a nationally ongoing phase 3 clinical trial going on in basically stem cells. Unfortunately, it's a kind of, doing stem cell studies is kind of difficult. You need a department. It's not something that an MS center could do if they weren't attached to a large academic center typically. So most of these studies are being done in academic research centers because the stem cell technology is actually quite difficult to deliver. So, so stay tuned though. If we're in terms of accessibility, the key here is going to be, like everything else the FDA focuses on, safety and effectiveness. So if this study proves the safety and effectiveness, then we will have an FDA-approved stem cell therapy for MS. I would only guess it's going to take 2 to 5 years. I'm hoping it's sooner, but it may take that long.
My understanding in the U.S. is that, follow-up to that question, is that it's only available if you're in a study. Is that correct?
Yes, no.
Oh, okay.
If you have enough money,
well,
it's
you can
America.
Go somewhere.
Yeah, no. If you have enough money and you want to go over to Northwestern and pay for it out of pocket, they'll do it. But your insurance won't cover it because it's not FDA approved. And so once it's FDA approved and the safety and efficacy, effectiveness has been determined and proven to the FDA satisfaction, then we will be able to fight with your insurance company and see if we can get it approved, okay? So, great. Yes.
Yes, I've had MS for over 30 years, and I feel better now than I have in the past. And people keep telling me how much I'm looking better. And, 25 years ago, I wasn't looking this good. So my question is, if lesions shrink at any point in time, do they fade away? Do they die? What happens to lesions over extended periods of time?
Yeah, very good question. And I think, our focus on, I'll say our lesion-centric focus in MS is determined a lot by the fact that MRI was our really first biomarker of this disease. And so the disease is, it's about way more than just lesions. So the lesions you see on the MRI are just the tip of the iceberg. Lesions do improve. Fresh lesion is most likely to shrink over time, and you can actually see lesions that will go away. There was a study done by the NIH, it's an old one now, where they did serial MRIs. They did set it up so they got exactly the same slice through the brain, and then I think they did them once a week for like a year, and then they made a very short movie out of this one slice of the MRI through somebody's brain. And what you would see, again, Stuart, I need 2 hands to pantomime this, but you'd see a lesion that went increased, contrast enhanced, and then shrunk and stayed. You'd see a lesion that came and went away. You'd see a couple of smaller ones that came and went away. You'd see a bigger one that came and then slowly shrank. And now, that was with weekly scans. We do the scans maybe every 6 months, once a year. So what we're missing between those slices in time is really quite significant. So while lesions are a decent biomarker, yes, they do go away. Some will go away. Go away is not really the right thing. They will improve to below the resolution of the MRI scanner, which is really a better way to say it. So they don't actually go away. So if you've ever had a lesion there, even if we can't see it on the MRI anymore, it still killed brain cells. Maybe one that improves enough we can't see it, didn't kill as many brain cells as some of the others, but if there was ever a lesion there, it did cause at least some degree of permanent damage. So yeah, that's great. Now, to you feeling better, good, excellent, amazing. And I have seen that. I have seen this, and in fact, most often this coincides when we take somebody, discontinue somebody's treatment. And I think that's something I actually neglected to mention. One of the most important things we're going to learn from our biomarkers, protein biomarkers, is we we can't identify someone where we might want to discontinue their treatment who we can do it safely in. I think with these biomarkers we might. So we know the immune system calms down as people age, and often if I take somebody off a treatment after a certain age, the interferon drugs often made people feel just sort of low level, low fevers and achy, and just a lot of people who stopped those interferon drugs when we first got the oral drugs said, I haven't felt this good in years. They just got used to feeling kind of low level crummy on the interferons, and they felt much better. Now, I do see people frequently who, as they age, feel better. Now, I can only speculate why that is, and some of them even neurologically improve. That's not the usual scenario. That's not what most people with MS experience, unfortunately. But I think there is a subset of people where the disease does kind of calm down enough that they're no longer having this low-level inflammation in their immune system all the time, and they just feel better. So perhaps it's pure speculation on my part, but perhaps that's what's going on with you. I'm happy about it for whatever reason, though. Yes, cross your fingers, yes.
Thank you much. Next question online.
Can black holes be reversed?
Qualified, yes. A black hole will be, depends on how, it's part of the definition really. So by definition, a black hole is something that is persistent after 6 months. So what a black hole is when you see a lesion on an MRI scan, when it first happens, there's going to be some fluid changes in that area of the lesion, and it'll look bright on one type of MRI, and a different MRI sequence, it'll look dark. So on the T1 MRIs, it looks dark, and we call those black holes. So when you have a fresh lesion, there's a white spot on the T2 and a black hole, or a dark, we'll just right now call that a dark spot on the T1 MRI scan. And over 6 months, if that dark spot is still there, after 6 months on the T1, the bright spot will probably still be there, although it might have shrunk like we talked. But if that dark spot is still there after 6 months, then what that indicates to us is that a lot of brain cells died. And in fact, you can even correlate with how dark the spot is with how many brain cells, what percentage of brain cells died. So black holes can, quote unquote, go away in the first 6 months and not be considered, really, technically a black hole is one that stays there after 6 months. That was an online question. I should have been talking online. So thanks for the question. It's a good one.
Next one's back here.
This goes into the genetics of MS, and with the DNA SNPs that are showing, any that show that MS is more susceptible to your progeny. For instance, my paternal grandmother had MS. My father had MS. I have MS. So is there something my children could look at to see if they need to start something now?
Yes. So the genetics of MS is still kind of the Wild West. The ultimate biomarker would be to be able to define somebody's genetic profile. It's really complicated. It's really not about the genes. These short segment changes that we see in the DNA are very important. I can't say that we really have it worked out to reliably predict somebody's risk yet, but that, along with the proteomics, the genetic biomarkers, the epigenetic biomarkers, these are going to be really huge for us too. But those are a little bit further away than our proteomics because they're here now and we're able to use them. But yes, it is very important. And I do believe we'll be able to identify at-risk offspring, if you will, from some of this technology.
Thank you. I have one remaining question. I don't think anybody else here has any questions. I know we don't have any online, so I'm going to ask you, let's see, how do we put this? All right, since you're in the talking a lot about biomarkers, what do we see coming for people to know soon? What is the best medication for them to be taking?
Yeah, the best medication is the one that you can take, the one that you can afford, the one you don't have a lot of side effects, and the one that completely shuts down your MS.
And how will they know?
Yes, how will we know? Well, hopefully, we will be able to, in a similar way, we use MRIs as far as frequency. Hopefully, we'll be able to do a measurement of your biomarkers and everything else that we measure about you at baseline, and then track your biomarkers when we initiate a treatment. So I think that's going to be one of the more powerful things we're going to be able to do with these tools. So initiate the treatment, or rather do the biomarkers, then initiate the treatment, then repeat the biomarkers roughly 3 to 6 months, and then probably periodically every 6 months or so. So I think that's how we're ultimately going to use them. And down the road, I think we're going to find even better ways to use these tools, and we're going to get better tools.
Thank you.
Awesome.
Let's
Thank
call it
you.
a night,
Thanks,
everybody,
everyone.
right?
Awesome. Thanks, Stuart.
Thank you.
Yeah.
Another great talk. Another great talk. So again, I want to thank everybody for being here tonight. Again, I want to thank our sponsors, Bristol Myers Squibb, Genentech, Sandoz, and TG Therapeutics for helping us to make this possible for all of you. And I'm going to say right now, good night to everybody online. And I'm going to thank everybody again for being here. Have a wonderful evening.